Hey, Vlad, are you there?
Hi, John. Can you hear me?
Hey, Llewellyn, how you doing?
I'm all right, John. How are you?
Good, good. I can hear you.
Okay, great.
Hey, Vlad, are you there? You're in there, right, Llewellyn? You're in there?
Yeah,
Okay. You got a camera, right?
unmute, put on my camera. How are you,
How
John?
good. How you been?
I'm all right, John. You look younger. I'm not joking. You look younger every time I see you, John. Clearly, the
Yeah,
Miami
right. It's the sun.
is the sun.
Yeah, yeah. So you've been busy?
We've been busy. Yeah, yeah. But I can't complain. Busy is good. It keeps you
You're
out.
in Cape Town, right?
I'm in Pretoria.
Oh, Pretoria. Okay. Like all these big cities are different, right? Cape Town, Pretoria, Johannesburg,
Yeah, completely. Completely.
completely different.
They're like the American cities, if you move from New York to Miami to, the more sort of southern towns, Texas, they're completely different. Yeah.
Yeah, yeah, yeah. Every town has its own character.
Yeah.
It's getting a very Latin country. I mean, we're getting very Spanish here in America. The blacks used to be the second biggest minority. Now the Spanish are
Okay.
second biggest, and they've really changed, influenced language. Like in LA and Chicago and Miami, you hear Spanish on the streets everywhere,
Yeah.
everywhere.
Yeah.
It's like a different. It's like Latin America. You know,
Yeah.
there's parts of Miami I feel like I'm in Latin America.
Sure.
100%. I worked at a clinic in Miami in an area called Hialeah. I never saw a patient that didn't speak Spanish. 100%. So you better learn Spanish if you're going to practice in the ER, anyways.
Yeah.
I don't know if you guys need it in neurosurgery. I guess around the office, you're going to need it.
Yeah. Yeah. John, do you know how many people registered this time around?
Let's see. I haven't checked here. Hold on. 156.
Okay, that's pretty good.
That's not bad.
That's pretty good. John, so the speakers are Rick Abbott and Francesco Sala, and then Mohammed and Moody Qureshi. So, I mean, I don't, would you're okay to sort of promote them up as you see them, or do you want me to give you a hand with that?
Yeah, you have two. You can have as many as you want, but you have two today, right?
Yeah, we've got two and then a few panelists, and then Mohammed's my co-moderator. So,
okay.
Probably about four, so yeah.
Mongolia, we have a Mongolian neurosurgery resident. Bayam Batsen, how you doing, Bayam? Let me get her in here. And Vlad's here. Hello, you know Vlad, right? Vlad Bennett.
I know.
We name drop here. Vlad, are you there? He just spoke. There was a neuroanatomy lecture. I don't know if you saw it.
I
A
saw
big
it. I
one.
didn't get to attend. Yeah, but I saw it. Looked interesting.
Yeah, that's has all big names there.
Mm.
They love it. 2 days, 4 hours each day,
Oh, wow.
and
Jeez.
they really go over neuroanatomy. I think they were honoring Rotan today. That was the theme, I think. You never met him, right?
Roton, once.
You did meet him in Florida.
Yeah.
You came to a conference here
Yeah. Yeah.
at his place.
No, it wasn't, but he was a speaker there. It was a while back. I was still quite a junior consultant then. So. So I see Mo's here. Mo.
Sometimes people just check in and then take a walk.
Yeah. He's on as a panelist. So. Oh, there we go, Mo.
Hi.
How are you,
Hi,
Mo?
Mohammed. How you doing?
Good to see you.
Let's see you.
Mo, so you're happy to, who do you want to introduce? Do you get that bio I sent you?
Who will start?
Yeah.
I think you can start.
Okay, I'll do that quick slide just to. So John, one of our sort of icons of pediatric neurosurgery, Michelle Zeral passed away this week. So we just want to do a quick slide and just, acknowledgement if that's okay.
Do you want to test something?
Yeah, let me do that. Let me open it. It's just a single slide. Let me see. There we go. That should be all right. You can see that, yeah? No?
Yes, I see it.
Okay, great. So we're just going to do an acknowledgement and a thank you and a rest in peace sort of, I think he was an icon and a mentor to a lot of us. It would be quite nice to do.
Really, pediatric neurosurgeon.
Yeah, from the Neckar.
From where?
From the Neckar in Paris.
Okay.
Wow. So I have.
Was it COVID related? Was it COVID related, Llewellyn?
I don't know.
Yeah. You're just suspicious. Every death that a person in their 50s, 60s, especially neurosurgeons.
So John, just quickly, if I can, and if you'll allow me, I see Keki Tyrell has joined. That's always it's always quite something to have a superstar neurosurgeon join. So Keki, do you want to say hello? If you unmute yourself, okay. Can you hear me, Keki?
Hi. Yes, I can. Very generous of you. Thank you very much.
I can't let you sneak in there unannounced, Keki. How are you? Nice to have you join us. It's such an honor to have you part of this, Keki.
My pleasure.
Welcome, Kiki.
Hi, John. Seeing you after a while.
Welcome.
How are you doing?
Very good. How you been?
And how is Florida?
Okay, excellent.
Yeah, good.
How are things in your neighborhood?
Yeah, it is raining every day. Very pleasant.
Is the COVID getting better? Same?
Pardon me?
Is COVID getting any better or is it the same?
COVID is under control. Yes, under good control in Mumbai.
It seems like most areas of the world.
But now the festival seasons are on, so I hope people will be a little more responsible and control themselves.
Yeah.
With religious festivals, Indians become crazy. Otherwise, in their behavior, they are very unreligious by habit. But when it comes to celebration, they become very religious.
Hello, Dr. Abbott.
Hey there. How are you?
Good. How you doing?
Good, thanks.
You know Zoom and all that stuff, right?
I'm sorry?
You know Zoom and how to screen share and stuff?
Yeah.
Okay.
How are you, Rick? So nice to see you, man. It's been a while, hey?
Yeah, Llewellyn is great. Great to
Yeah.
see you.
Yeah,
Yeah.
You know Mohammed and Keki. Hey, Rick.
Hi.
Yeah.
Hi, Rick. How
Hi.
are you?
I'm
Hello.
good, thanks.
Good to see you.
Hi there.
Hi.
Rick, do you want to do a test run quickly, or you comfortable?
Let me get my presentation up.
Okay.
Sure, if you have any videos or anything?
They're embedded in the presentation.
Okay, so there's no problem with them. You want to go over them?
I can put one up right now.
Yeah, if you want, we could just run and test it. Sometimes they get tricky.
Well, actually, if they don't work, it's no big loss, but
Okay, all right. Mm. Excuse me for a minute.
it seems to be playing on my end.
Yeah, it looks great.
Yes, it's fine.
Okay, good. So we're good to go.
Yeah, works fine.
Fantastic.
Mm. Oh, I want.
So how are things going in New York, Rick?
Yeah, pretty calm. I'm actually up in Massachusetts right now. We have a place in the Berkshires.
All right, right.
So I'm spending most of my time up here now.
Okay. Right. Yeah. So are you on leave? Are you on vacation, or is it just a sort of you're spending more of your time there?
So what I've arranged with my department is I work Thursdays and Fridays. And my job principally right now is just shadowing my junior associate and, helping him on the courage side to make the decisions that he needs to make on cases and
Right,
passing on little tricks that I've learned along the way.
right,
So
right.
it's kind of nice. I do a lot of teaching.
Yeah. Nice.
So I'm up here the other days of the week, up here in the Berkshires. I got a wood shop and I putter around doing that and taking hikes and enjoying being with the family. And it's really nice.
That sounds fantastic.
Yeah.
Absolutely. Yeah. Yeah. Did you guys ever get somebody to fill in for Jim eventually, or whatever happened?
We've been looking for about 5 years now.
Okay.
So I don't know, I just went to this schedule in the summer because I'm just tired of waiting. I figure if I don't do this now, I'm never going to get to do it. So fortunately, the younger guy, his name's Andrew Kobitz. He's coming along fast. So, worst case scenario is not going to be a bad deal at all. And that would be for him just to take over. So I think, it'd be a little rough for him administratively and politically, but as far as taking care of the patients, he's very good already. So.
Sure. Yeah. Been a while, hey Rick. Geez, it's been ages now that I see you again. It reminds me how long it's been since we last met.
Yeah, I know. It's amazing how fast time flies.
Yeah, yeah.
I can't believe it's been 3 years since the last ISPN meeting, and the last one I went to was in Tel Aviv, and that was 4 years ago. For God's sakes,
Right, right.
it's amazing.
It's ridiculous. Okay, Rick. So how long is your talk, more or less? We've scheduled in 45 minutes, so just take as long as you want, really.
Yeah, I think it'll probably be less. I haven't timed it out, but there's probably 30 slides. It's basically going to be walking through the history of working with Fred and how things developed here, and it should lead in well with Francesco.
Okay, right, fantastic. Fantastic.
Kiki,
Look at who's there.
Hello.
Hey, Vladimir. How are you?
when is the next complication meeting?
It's on. It is clashing with your meeting with endoscopy guys on 24th September.
Let me know.
One more time, there's been a clash. This is
I've had one complication to present.
so. I would love it. What is the topic? If you have, I'll put it on the program.
It's vascular for me.
Sorry, you'll send it to me. You'll email it to me.
I will mail it to you.
Yeah, but
Okay.
would you be free to be a discussant, or would you be busy with your meeting? You will be busy with your meeting. Would you be? How will you manage it?
What do you mean?
Your neuroanatomy committee is also having a meeting same time.
Oh, yeah, we just had a seminar which was excellent in honor of Al Rotten,
Yes,
and we have the next one tomorrow, 2 p.m.
Yes.
Central European. It's like
Yes.
6 hours more for you.
yes.
And tomorrow the program is like extremely good, so join.
I would love to do that. Yes.
Yeah, join please, and
Yeah.
let me really know about the complications meeting.
It's on next Friday.
Next
Friday. Yeah.
You
24th.
you didn't let me know, so we didn't give you a case. Can we still give you a case?
No, of course, no, the man. You have received the email. Everybody receives the email. You are on the core committee. But
I didn't get
I
it.
believe you also have a meeting with the endoscopy guys on the same evening.
We do. So it's consequent, or is it one after the other?
No, almost parallel.
I see. So I shall ask one of my residents to present on your on complications. Is it all right with you?
No, it'll be nice if you could step in for a while. It's only a few minutes.
Depends. You know, I'm too much involved in the other one.
Yeah, I know.
I'm sorry for this.
But never mind, if you have a resident, it's also still more than welcome. I will
do my best.
but please send me tomorrow.
I will. Tomorrow you have it. It's a nice case of distant hematoma after the minor surgery.
Tell me on what subject it is. I can make a slot.
Distant intracerebral bleeding after minor surgery elsewhere.
Okay. All right. Great. Very good. This topic has caught on very, very well. Everyone likes to listen to this because these are major problems after relatively minor surgeries. So people find it, especially the young students, find it extremely useful because what they would be doing as minor operations, and they would be,
True enough.
yeah.
We have written it also as a minor article. I was told that it will be published somewhere.
Yes, it is already on the repository. It's on the repository.
Okay.
So if you look at the Neurocomplications website, you will find it.
Very good. Will do.
And then 2 months later, we are having
In 2 months' time, before Christmas.
In November, we have with the neuroendoscopy group complications on neuroendoscopy,
Okay.
intraventricular and extraventricular.
You join? Sure.
How is health keeping good?
Yeah.
Life is all right? Yeah.
Quiet.
I think there's a plague of webinars. It's hard to cope up with.
Plenty. Probably too many.
Yes.
We need to meet in person finally. It's boring already.
Yes. If our governments and airlines allow it.
Yeah. On the other hand, for young people, this is for free. no time consuming, no flight, no hotel, no fee.
Yes. Yes.
This will survive even after.
Yes. I think people will get so much used to this that they may not want to travel.
Exactly. Well, so we shall keep it to ourselves then.
Yes. Yes. It's cheaper, so much cheaper.
Yeah.
Well, what are we going to do? Saving so much
Well,
money.
let's do shorter meetings with longer vacation after, like Zimbabwe we have had several years ago, or Kenya.
Oh yes. Oh yeah. Oh those South Africa, all African continent. It's so
Anytime.
amazing.
Anytime.
So amazing.
Yeah. KK, do you have few images when we were together in Iran? I already have asked you.
I sent you.
Do you have something from that old city of Yazd?
I sent
It's
you
on
whatever
AZ Adder.
I saw. I tried to look for you in those pictures.
No, not for me. I'm not really that eager to be on the picture. I would like to get pictures because I had few, but my
pictures
computer
of-
went down and I never saved that.
Oh, I have all the pictures. I mean, I thought it was only where you were located.
No.
Oh, then
Even
I will-
nature, landscape, whatever.
oh, that's plenty. I got plenty.
So
You
send
remember-
me few.
Yeah. We had that meeting in the
Put
fire.
it down, write it down, please.
We had
Otherwise,
meeting-
you would forget.
No. It's already here. The pad is right here. I'm always with a paper and pen, old-fashioned.
Thank you.
So I'll make a note right away. Pictures for Iran pictures for Vlad. So I would be having several hundred pictures. I don't know thousands, but several hundred pictures. So I'll see. Maybe I can put it on a pen.
15 is enough, especially that old city we were in. Do you remember that? With
I
that,
remember. Yeah.
strange air conditioning of the ancient times.
Yes. That was a Zoroastrian city, actually.
Very much so. That was beautiful.
Yes. And we had a good explanation by the local priest.
Oh, yeah. That was great.
And I have the picture of the fire temple as well,
Oh, yeah.
which I could take from
And
inside.
probably of the guy who was chairing the trip
Yes.
with all the ceremonies.
Yes.
Okay, gentlemen, I'm just going to ask John to. I see we're almost on time now. John, are you still there?
Hold on. Yeah.
Okay. I see Francesco's not.
We start about 1 minute, okay, Llewellyn?
Yeah, that's good.
Hello, Vlad.
Hi, John.
How
How are
you
you
been? I haven't seen you in a while.
Yeah. No. I've been joining directly. No. I don't know. Do we have the WFNS course via your TV or not?
Yeah. No, I've
So
seen
we
you
must
now
have
and
met
then.
in
I've
the
seen you now and
afternoon.
then. And I've shouted out to you, but you must have stepped away or something. I don't know. Yeah, let me get the camera on. I don't even have it on. Okay, Llewellyn, you ready? Or did he step away?
Thanks, John. Sorry, I just said something. Okay.
Oh, are you ready? Okay, 10, 9, 8,
yes,
7. You ready, Llewellyn?
I am yeah, thanks.
Okay, you're all set?
Okay, great.
Okay,
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami, home of Neurosurgical TV. We have the honor of having the CAANS Pediatric Spine Group, who part of their spine module, that have a couple of presentations today, and I'll turn it over to Llewellyn Padiaki to run the show. Good day, Llewellyn.
John, thank you so much. Thanks once again for all your effort in sort of putting this together and helping us with so much of the logistics and administrative work. And then welcome to all our attendees, specifically my co-host Mohammed Al Beltagi. We should have joining us from Cannes, Moody Qureshi, the president, and incoming president Belui Sheho, and possibly also Nasser Al Gander. So I would like to firstly welcome our esteemed, internationally renowned pediatric neurosurgeons, Professor Rick Abbott from Montefiore in New York. As he says to me, he's currently spending more time in Massachusetts than New York, and Francesco Sala, again, renowned for his expertise in intraoperative neurophysiological monitoring. So before I start, I think with permission from all the attendees and John as well, I think it's only fair. So we have recently in the past week or so lost an absolute icon in pediatric neurosurgery, somebody who was a mentor to a lot of us, a giant in pediatric neurosurgery. So I think it's only fair and fitting, given the kind of credence and of this crowd, that we just take a second and just maybe a few seconds silence to pay homage to Michel Zerard, who was an absolute giant in pediatric neurosurgery. Okay, thank you very much for indulging us with that, John. I'm going to then kick things off between Mohammed. Mohammed, you want to say a few words before we are introduced? I'll introduce Rick and then you, Francesco, Mohammed.
Yeah, just want to thank you for this hosting, John, as usual, doing an incredible job, and for Rick for accepting our invitation, and Francesco, of course. We are trying to establish pediatric neurosurgery in the CANS, the Continental Association of Neurological Surgeons, and this is pediatric sessions that have been run every second Tuesday of every month, and that's almost our 7th month. So thanks for the support and looking forward to yeah.
Okay. Thanks, Mo. Maybe just a point that for October, we probably won't run the seminar because of the ISPN African cause, but I'll leave you at the end to mention whether we do that or not. Okay, so this session has been dedicated to spinal cord tumors, and I cannot think of two more prominent and more fitting people to give these talks than Rick Abbott and Francesco Sala. So Rick is Director of Surgical Neuro-Oncology at the Children's Hospital at Montefiore and Professor of Clinical Neurological Surgery, Clinical Pediatrics at the Albert Einstein College of Medicine. He trained under and was under the mentorship of the famous Professor Fred Epstein, who molded a lot of Rick's thinking and surgical expertise, as he will well acknowledge himself. And Rick has continued in his own style in this legacy. He's held numerous posts in national and international pediatric neurosurgery organizations. I would have thought most notably as the president of the ISPN in 2008. And I remember that distinctly because he came down to Cape Town with his red poncho. He's the editor-in-chief for a web-based textbook on pediatric neurosurgery, the ISPN Guide to Pediatric Neurosurgery. He's authored numerous journal articles on hydrocephalus, neuroendoscopy, including the management of complicated shunted hydrocephalus, treatment of cerebral palsy, brachial plexus injuries in children, and tumors of the central nervous system. He's also worked in South America, Africa, and Asia to instruct in the use of neuroendoscopy for the treatment of hydrocephalus and other topics of pediatric neurosurgery. We're particularly privileged in that Francesco and Rick have spent quite a bit of time together, both training under Fred Epstein. So it's going to be a distinct pleasure. Rick, and with that, I'll invite you to give us your talk. Thanks.
Well, thank you, Alan, for such kind words. Let me get the presentation up. Okay, what I'm going to do today, I thought it would be appropriate just to set up Francesco's talk, because he really has the important message to drive home. But to set that up, I thought I would go through the evolution of intermedullary spinal cord tumor surgery that I was privileged to watch as Fred went from just flying by gut instinct on what he could get away with to really giving us the tools that any neurosurgeon now can effectively deal with this pathology surgically. So when I joined Fred, it was in 1986, and at the time, there were about 3,400 tumors being diagnosed in the central nervous system of children every year in North America. 4 to 10% of these were spinal cord tumors, and so effectively that means that 130 to 340 intramedullary spinal cord tumors were occurring every year in North America. At the time when I joined Fred, he was performing surgery on about 30 to 35 of these children in the practice. And that continued through the 90s, essentially until the time of his bicycle accident.
I have to click on the slide for it to move, Rick. I don't know why it does that.
There we go. So the surgery that Fred performed at that time consisted of a laminectomy. The typical extent of the laminectomy included both any cyst that was associated with the tumor as well as a solid tumor. He'd then perform a midline myelotomy at times with a scalpel, at other times with a laser, a CO2 laser. He would then perform a central debulking of the tumor with a ultrasonic aspirator and would laser any remnants that were visible at the end of the resection. There was monitoring present in the operation. It was basically experimental attempts at developing the skill set for monitoring intraoperatively, consisted of somatosensory evoked potentials, some very primitive equipment looking at the potentials on oscilloscopes, and the information was very unreliable, very spotty, and was not utilized in any surgery decision-making. The extent of resection that Fred would accomplish at that time was basically driven by his instinct and what he could get away with, as well as the most immediate experience he had had with previous patients. So the extent of the resection was variable and the outcomes were variable and unpredictable. So obviously unacceptable to have that sort of a situation going on in the operating room. And Fred, because of this, sought out advice and received some excellent advice from Milan Dmitrievic, a neurophysiologist and neurologist who was working in Houston at the time. And Milan introduced Fred to Vedran Delitas, suggesting that he would be a valuable addition to our team. And Vedran joined us in 1988 to develop intraoperative monitoring. We would perform surgeries after Vedran joined us. Any spinal surgery that exposed the spinal cord or cauda would typically have an additional 30 minutes added to the surgery time, and Vedran would be allowed to work on development of stimulating parameters and recording parameters, as well as develop the equipment. And so within a year, he was able to give us reliable D-wave recordings or recordings of this evoked potentials that were present within the cortical spinal tract in response to transcranial stimulation. And so it was from that point on that we started to develop an experience using intraoperative evoked potentials to guide surgery decision-making. And by 1983, he had developed the ability to record evoked EMG activity in response to transcranial stimulation, the so-called MEPs. And the year following that, he added the bulbar cavernosus reflex recordings, recording that was a reflex circuit that involves stimulation of the pudendal nerve transcutaneously and recording of the evoked anal sphincter contraction. So effectively at that point, we could monitor any level of the spinal cord from the cervical medullary junction down to the bottom of the conus and have a potential driven through an area of the surgery that we could follow with during the resection. Carl Kochbauer, who unfortunately we lost last year. Carl joined Vedran for a fellowship in the mid-90s, and one of his projects was to look at the outcome of the early experience and monitoring of motor evoked potentials. And he looked at 100 children and made some very interesting observations that really drove home the importance to us of the monitoring. He found that any child that had difficulty recording a D wave initially at the time of exposure, any child like this would have a very high risk of losing function during the surgery, regardless of what the potential showed. He also found that if the EMP or the MEPs, or in other words, the evoked EMGs, if they were preserved, if there was no changes in those potentials during the surgery, there would be absolutely no change in the motor function of the child. They would awake and essentially be able to walk off the table and back to the recovery room and would go home after a very short stay in the hospital. On the other hand, if the MEPs were lost, but the D wave was preserved, or at least more than 50% of its of the amplitude of the D wave at the time of the start of the case, if that was preserved, there would be a postoperative motor deficit. The child would require rehabilitation, but the child would successfully go through the rehabilitation, and the deficit that they had after the surgery would only be temporary. On the other hand, if the D wave was, the amplitude of the D wave decreased more than 50% of what it had been at the start of the case, that patient would have a long-term motor deficit that would be permanent and would typically be a plegia. There was a lot of controversy with that paper, and it was largely resisted. The information was resisted in subsequent attempts at publication. So we really had to wait almost a decade for there to be widespread acceptance of use of the motor evoked potentials during intramedullary spinal cord tumor surgery. Francesco Sala, who will be speaking next, came out with a paper in 2006 that essentially closed the argument and resulted in the acceptance of the monitoring. He, after spending time with Vedran, returned to his home in Verona, and part of his work there was to establish interoperative recording of motor evoked potentials that were utilized by Briccolo in his spinal cord tumor work. And Francesco came out with this paper in 2006 that compared the results of that, of using the D-Wave and MEPs with results of patients where that was used, and compared that to a historical control before the use of motor monitoring, and showed a clear benefit with regards postoperative function in the patients. And as I say, that led to the acceptance finally of motor evoked potential recordings guiding surgery for resection of intramedullary spinal cord tumors. So now the current technique is largely results from the information we've learned from the monitoring of the patients as well as other pieces of information we've learned over time. We now do a laminotomy and no longer do laminectomies. The main reason for this is it's cosmetically more appealing to see the back if the bone has not been removed. The extent of the laminotomy, we've learned that cysts, as shown in the ultrasound here, unless you see a clear bulk of tumor within the cyst, there's no need to expose the cyst. And so we will just do the laminotomy over solid tumor and not over cysts. We use an ultrasound once the lamina is off to ensure that we have adequate exposure for the solid tumor. And now we place an epidural electrode caudal to where we'll be working for recording of the D waves. Typically, we'll also put electrodes in the muscles of the extremities to caudal to where we're operating, is to get not only the D wave from the epidural electrode, but also the MEPs. And so we'll be monitoring both. The opening, we had a great deal of problem, particularly with adults, but also with children to some extent in postoperative sensory deficits. So I've tried to minimize the amount of injury to the normal spinal cord parenchyma as we approach the tumor. We approach typically we'll approach the tumor through the midline median raphe unless the tumor actually has broached the surface of the spinal cord and lays just underneath the dura. Just underneath the pia. The hint about where the median raphe is, typically you'll see blood vessels moving towards the midline and all of a sudden disappear as they dive into the median raphe. And that'll be my point where I'll make a sharp incision through the pia to start opening up the median raphe. I will do spot cautery with a neodymium YAG laser if need be, but it's very, very unusual that we have to do much in the way of cautery on the surface. Then this is an instrument that Fred developed. It's a plated bayonet, and it does a very gentle job of spreading the median raphe open. As we open up the median raphe, what I'm looking for are vertically oriented blood vessels, as you see in the mid area of the myelotomy. That tells me that I am in the median raphe, when it's a good opening, you'll see those vertical blood vessels on either side of the raphe all the way down to the tumor. Once the dorsal surface of the tumor is exposed, we do a central debulking using the ultrasonic aspirator. And then continue to aspirate. In children, 90% of these tumors are going to be either astrocytomas or gangliogliomas. And in those cases, what we're doing is using the aspirator to suck the tumor away from the parenchyma. And when you're getting towards the periphery of the tumor, you'll start to see areas of white matter become exposed as you suck the tumor off of them. And that's your signal to stop. What was learned at one point in a paper that I'll be discussing shortly by Shlomi Constantini is that 90% resection has the same 10-year survival outcome as does a 100% resection, both with regards mortality and with regards progression of the tumor. We're not trying to get all of the tumor out. We just want to get into that 90% range, and then anything after that we'll remove as long as the monitoring is holding up. With regards to any bleeding, the most problematic bleeding is going to be at the depths and midline where you have branches coming off of the anterior spinal artery. We'll do everything we can to avoid cauterizing in that area. Most of the deficits or loss of motor potential that are significant clinically, most of those occur at the end of the case, and there's not an inconsequential incidence of vascular infarcts due to cauterization down in that area. So we'll use a lot of time and tamponade with hemostatic agents to try to control that type of bleeding before we finally give up and use cautery. So this is a case that I thought I'd just discuss real briefly because it has several points that illustrate our learning curve and factors that have led to modification of what we do. This was an 11-year-old boy that came to us with a history of having developed a head tilt and pain in his left shoulder, and a month later was starting to have frank leg weakness that led to the imaging being done. Head imaging was done, and that showed bilateral acoustic neuromas. So he was presumed to have neurofibromatosis type 2. And then in the spinal area, he had a lot of tumor. He had intradural and extradural nerve sheath tumors at several layers in the mid-cervical area, it actually napkin ringed the spinal cord. And then intradurally, the intramedullary, there was a tumor central in location that we felt was an ependymoma. So intramedullary ependymoma and several nerve sheath tumors. So we set out to deal with this. He was becoming rapidly paraplegic. At surgery, our first step was to decompress the spinal cord by removing the extradural and intradural extramedullary nerve sheath tumors. This was done with no problems at all, and monitoring held up for that part. But then we started to work on the spinal cord tumor. I did a myelotomy for the entire length of the tumor, and as I started to work up at the apex of the tumor, the red arrows on the left show that the evoked EMG activity in the legs, the anterior tibialis, started to drop and then evaporated. And shortly thereafter, we started to see a drop in the D wave, and at one point it went down to less than 50% of the amplitude. So at that point, I felt like we really couldn't push it. We did wait to see if we had any recovery, and there was really no rapid recovery. But fortunately, when the child awoke, he did have anti-gravity strength in the legs, but had some dysesthesia in the left leg. 2 days after surgery, however, on morning rounds, our residents found that he had lost anti-gravity strength in his left leg overnight. And for that reason, he was taken back to surgery. And unlike the first operation, the second operation, we had no problems with the D wave being unstable. You can see it on the right side of the screen there, and its amplitude held throughout the case. On the left side of the screen, you'll see that as we started to work with the tumor, we started to see recovery of the evoked EMG activity. The child came out of surgery with preserved anti-gravity strength, and by the time of discharge a week after the surgery, he was weight bearing using a walker. So we were able to get all the tumor out and preserve his functional level. By 6 months of after surgery, he was fully recovered with regards to his motor strength. There were several lessons that we learned on this. First of all, I think that at the time of surgery, when you initially do the myelotomy, you could be dealing with an ischemic cord. Historically, Ellsberg, back in the early 20th century, made the observation that with a patient with an ependymoma, that they could do a myelotomy and then close the case and come back a week or so later, and the tumor would have by that time delivered itself from the spinal cord, and they could just simply pull the tumor out without any threat to the patient. So I think there are patients where you can have an ischemic cord that's intolerant of an initial attempt at debulking or removal, but that by doing a myelotomy, you can get the tumor to decompress itself a little bit, and with that, you'll see an improvement in the perfusion of the cord and an increased tolerance for the surgical manipulation required to remove the tumor. So I think monitoring is a tool that you can use to see if you're in that sort of a situation and understand how aggressive you can be with a tumor. We have since changed our technique, and we're much more willing to stop a surgery. And in fact, we'll tell our patients before their first surgery that we may be stopping the surgery, giving them a period of rest, and then returning to the operation or return to the operating room a week or so after the first surgery to have another attempt at the tumor. It does not uniformly work. We've had a couple of patients where we tried this on that they had the same problems with degradation in their monitoring with the resection, but in other patients, we're able to get the type of surgery or results that we're looking for. This is the boy's scan after his surgery, and you can see there's been a good removal of tumor. The area of this is an unenhanced MRI scan in the area of increased signal you see at around C3 on the sagittal in the left upper panel was blood. So as I mentioned earlier, Shlomi Constantini published a series in 2000 in Journal of Neurosurgery about the experience with 164 children and young adults that were operated on by Fred in the 1990s and the 1980s. This was a very strong effort on the part of Shlomi that taught us a lot about the histology of these tumors and the expected outcome with children that go through the surgery. Importantly, what he found is that nearly a quarter of the kids and young adults had loss of function associated with the surgery, but most of those were pre-monitoring. After the introduction of monitoring, less than 5% of the patients had a decrease in their functional capacity after their surgery. So sort of a confirmation of what Dr. Salas observed with Dr. Bricolo's patients. There was no correlation with the age of the patient, the size of the tumor, or the location of the tumor. There was a correlation, however, with the grade of the tumor. High-grade tumors, not surprisingly, did not do as well as the low-grade tumors. And it's those patients that were the patients that were destined to die from their disease. In about 10 years ago, we went back and used Shlomi's spreadsheets from his original study to try to contact the patients again, and we were able to contact 20 children and an additional 24 young adults from Shlomi's study. With regards to children, 20 of them, they had an average age of 10.2 years, and their follow-up at that point, the mean was 18 years. So this is very long-term study here, or long-term results. Functionally, same lesson with regards monitoring. The declines in function to a level where the patient was dependent upon others for their day-to-day care. McCormick scale, these are 4 and 5s, were all in patients that did not have monitoring for their surgery. There was no patient after 1992 who had difficulties with regards being dependent upon others for daily tasks. All of the deaths that occurred in the patients that we called back had occurred in individuals with high-grade tumors, and all the patients that had low-grade tumors tended to have stable function throughout their 18 years follow-up, or they had improved slowly by 1 grade on the McCormick scale over those 18 years. So the simple lesson that I had, having watched Fred develop these capacities, is summed up with an anecdote that I tell people frequently about working with Fred. I was a fellow and I was watching him do a spinal cord tumor, and at this point I was late in the fellowship and I'd seen him do many of these surgeries. And I asked Fred, so when do you know to stop? And he said, well, it's just kind of the feel that I have. And I looked at Fred and I said, wait, Fred, you haven't taught me a damn thing. I'm just going to send the patients to you. That's the only thing I can assume or say that I've learned from this experience. How am I supposed to know when to stop? Fred wasn't satisfied. And what he did during his career, we owe a great deal to him because he gave us the tools, particularly the monitoring and assembling the personnel that really developed it. Dr. Delitis and fellows like Dr. Koch-Bauer and Dr. Sala, they're really the people that developed the ability so that now all of us can do this type of surgery. So on that note, I guess I'll turn it over to Dr. Sala.
Thanks, Rick. I think we were just, Francesco, you're on, yeah?
Yep, I'm here.
Great.
Hi.
Welcome, Francesco. I saw your message. Great that you could join. I'm just going to sort of stop a second just to stimulate some discussion, Francesco, and you're welcome to join in that. John, can I ask you to just elevate Muri Qureshi to a panelist? I think he's got a question. So Rick, just maybe I could kick things off and ask you something. I don't know if you remember when you came down to Red Cross when we did that hollow cord tumor in that kid. and you were sort of explaining to us how we're going to do this laminotomy, and it will take all of 10 minutes. And I said, yeah, no ways. I've got to see this. And then you sort of
No,
zip
you
through
were all set to spend the day at it, I think.
exactly, and zip through this thing. It was almost from, I think, T10 all the way down to C2. I mean, do you want to just walk us through the principles of the laminotomy? I think that's a lot of things that a lot of, that concept people struggle with. And I certainly do it exactly how you taught me to.
Yeah, so I've forgotten exactly how I got into doing that, but it was either a paper or a colleague that showed me how to do that. And as I thought about it, it's a pretty easy thing to do if you're talking about a child or a young person. I would never do it in an elderly individual with canal stenosis. That would be pretty stupid. But I really haven't run into any problems with regards injury to the dorsal columns and what have you, even in tight cords like this kid. I don't have any hesitancy for doing it. It's pretty easy. We do a standard a dissection at the caudal interspace that we want to start the laminotomy at by detaching the ligament, ligamentum flavum. Then I use we've always had the Midas Rex. I've used the Black Max on one or two occasions, but my experience is basically with the Midas Rex equipment. I put the foot plate in at the space and try to keep it at the part of the lamina that's starting to sweep up and has made the turn and is starting to move dorsally into the facet. So that's usually the hollow or the ventralmost point of the surface of the lamina. Is where I'll try to make my cut. I usually am trying to get about 1 centimeter or so width. And the only thing to remember when you're doing it is that the lamina, as you move caudal to the cephalad, on each one of the lamina is going to have a ventral slope to it on the inner side. So if you're, most people are scared of the instrument and they're lifting up. And what will happen if you lift up is the foot plate will go right into the lamina and you won't be able to progress. So you have to kind of keep that in mind. But then once you get going and get used to it, and I've done 1 or 2 of these, it's quite quick. And with the Midas, with these high-speed drills, it's very easy to control them, particularly on a child with soft bone. So I wouldn't advise starting off with adults learning this technique. I think it's really hard with adults, particularly those with big spines. But with children, it's quite easy to do.
No, thanks, Rick. That's fantastic. So I think that if I could just move over to the question. So Moody, you had a question on the temperature of the watch. You want to ask that, Moody? Moody, can you hear me?
Thanks, Llewellyn. Thanks, Rick. I was listening to your talk and learning from it. But I'm just wondering whether during the surgery you have any particular advice on the temperature of the irrigation fluid that you use?
Yeah, we typically have it lukewarm body temperature. I don't like ice cold because it'll knock the potentials out.
Okay, so but you wouldn't want to increase it for any reason either.
No, I have not run into the need to have to do that. We'll troubleshoot it, make sure that it's the appropriate temperature and not ice cold. But if we've lost our potentials, I'm a little reluctant to fiddle around with things and try to juice the system, so to speak. Because if you're going by the amplitude and loss of amplitude in the D waves, and you've established baseline potentials and everything was fine, and then you lose them, I don't know that you're going to end up with the same results as you would if you didn't do that sort of a thing. In other words, you're not responding to the warning signs.
Okay, great. Thank you.
Okay, thanks, Moody. Mohammed, any questions? I see I'm going to read. There's a Hitesh Kumar asking, should we do screw fixation in these cases to prevent kyphosis? Rick, maybe you take that.
Yeah, this Fred had that question back in the early 90s. What do you do with patients that develop scoliosis? So is there a need to prophylactically fix their spines because of that? And when they went back and looked at all the patients at that time that were developing scoliosis, what they found was tumor recurrence. And their feeling was that it was the tumor recurring that caused the scoliosis and not any innate instability that was created by either the bone work or the fact that there was muscle weakness associated with the initial tumor. So I don't know that, I don't think that we have a huge experience with problematic scoliosis that would mandate a prophylactic fixation. I don't know, Francesca, do you guys have any different feeling about that?
No, I agree. I mean, sometimes you have some of these children develop deformity, but I would never put prophylactic screw or no, we don't do it as well.
Mohammed, thoughts?
Yeah, I just have a question for you, Rick. In case of an intramedullary tumors in an intact child with diffuse gliomas, have you tried giving chemotherapy after a biopsy as a low-growth protocol chemotherapy before doing the resection in some of these cases? Or?
No, we have not done that. The concern about that, one is there's no big experience with that, at least as of the last review that I wrote. There was really no series in there that could definitively tell you that there was a efficacious chemotherapy that you could use. Secondly, my concern would be that if you remember, I said that patients with poor monitoring did not do well with the surgery. And there have been other observations that were done during these reviews by Shlomi and others of these patients, that the worse the patient was going into the surgery, the worse their outcome was. That if they had significant neurological deficits, they had a higher probability of having worsening of their deficits with the surgery. And the patients that were essentially normal going into the surgery, they did wonderful. They essentially came out of the surgery with a good resection and good results. So I think anything that would delay them getting into the operating room to have their initial attempt at removal of the tumor is going to add to the risk for them having complications.
Yeah. Okay. Any more questions, Leila?
Maybe I see we've got some fairly experienced neurosurgeons. Keki, any comments? I'm sure you've treated a few of these.
I have a number of comments, couple of comments, I would say. So the first comment is that location of the tumor is very important with regard to the neurological deficit. And I found the tumors in the conus area or lower dorsal cord did not do as well as tumors elsewhere. There's a general fear that those in the cervical cord or cervicomedullary region would not do well. But I thought the worst patients were those where the tumor was located distal dorsal cord or the conus. That was an important point that we have noticed. And the second thing is, I know that many people do not care much about vascularity, and I've seen number of eminent surgeons coagulating whatever came on their way, especially when you're doing a midline myelotomy. But I've been particularly careful, manipulating sometimes mobilizing the vessels. Of course, never to miss the midline. You can't go zigzag, but you can mobilize the vessels, especially those midline corkscrew vessels which are waving. Sometimes they go from right to left and left to right. And I don't buzz them. I gently pick them up and separate them from the cord tissue and manage to avoid coagulating them. And sometimes do a skip myelotomy, as I call it. That means you may not necessarily do a full myelotomy, which may require sacrificing the vessel. So wherever the vessel is crossing the midline, I would skip that area and continue with my myelotomy above and below or beyond them. So I preserve the blood vessels, veins, arteries to the best of my ability. And therefore, irrigation. Actually, spinal cord tumor surgery requires a good assistant. This is one case where I would want to have a very good assistant assisting me with irrigation and with whatever else that you require. So more than any brain surgery also. So these are two important points I'd like to make.
Yeah, I agree that the tumor in the conus area is the most difficult tumor to get the type of resection that you would like to get. And I think it's largely a reflection on the monitoring that we're able to do in that area. It's just, a reflex circuit that requires a synapse is not going to be as useful in monitoring as a circuit that has no synapses. So if you're using the D wave to watch as you're working, that's going to be a very reliable signal. If you have it, the only thing that's going to cause it to go away is going to be something bad. If you're talking about a bulbar cavernosus reflex, you're talking portion of that reflex is sensory. We know that the sensory area is much more vulnerable to injury during the resection. And then also there's a synapse. So anytime there's a synapse, you're going to have a much more vulnerable monitoring potential that you're watching. So it's not surprising that we don't have quite the courage down in the conus that we have elsewhere in doing aggressive resections. So yeah, I agree that most, I have more than a few patients with residual tumor in the conus area. So that's what I have to say about the conus. And as far as the myelotomy goes, I agree. I think since Fred would early on in his experience, he would cauterize all the vessels on the dorsal surface, and and usually it was a swath that was maybe 3 or 4 millimeters wide of cautery, and yeah, they're not arterial vessels, but still, you got an ischemic cord that's under pressure, and now you're going to add to it by cauterizing a bunch of veins. It doesn't make, to me, it always seemed like, if you don't have to do it, why do it? And you're exactly right. You can mobilize a lot of those vessels and get them out of the way, and it's pretty unusual that we have to do a lot of cautery. I've had problems with trying to do the skip myelotomy though, because if you're needing to get lateral in a tumor that's wide, it's going to be a problem, and usually, remaining areas of the that you've avoided a myelotomy in, they'll open up on you, and they may or may not open up that vessel at that time. But I think, the bias not to take vessels, I think, is a good bias.
Okay, thanks, Rick. Thanks, Kaki, for those comments. Mo, I'm going to hand over to you to introduce Francesco before you say this.
Yeah, next we have Professor Francesco Sala. He's a professor and chair of neurosurgery at the Verona. His main field of interest are pediatric neurosurgery and intraoperative neurophysiology. In 1995 and 1998, 1999, he worked in New York as a research fellow at the New York University, neurosurgery fellow in intraoperative neurophysiology at the Institute for Neurology and Neurosurgery, respectively. Upon his return to Verona, he established the Integrative Neurophysiology Unit at the Department of Neurosurgery, and in 2005, he was a co-founder, and in 2013-2015, the president of the International Society for Intraoperative Neurophysiology. One of his main fields of interest is the intraoperative neurophysiological assessment of motors during central nervous system tumor surgery. Following his clinical fellowship at the Division of Pediatric Neurosurgery of the Hospital for the Sick Kids Children in Toronto, in 2009, he was appointed as a responsible for the Pediatric Neurosurgery Unit and the Institute of Neurosurgery in Verona. Currently holding appointment as executive board member with both International Society for Pediatric Neurosurgery and the European Society of Pediatric Neurosurgery. His research interest in pediatric neurosurgery embraces functional surgery of central nervous system tumor, Chiari malformation, and spinal dystrophism. Professor Sala is particularly committed to the training of young neurosurgeons and the development of intraoperative neurosurgical community. In 2016, he was appointed at the first chair of Neuromonitoring Committee of the World Federation of Neurological Surgical Society. Since 2018, he is a board member and scientific chair of the European Association of Neurological Societies. In October 2020, he was appointed as the vice president of the Italian Neurosurgical Society. Thanks, Francesco, for accepting our invitation, and please, looking forward for your presentation.
Thank you, Mohamed. It was really a too kind introduction. So I'm so glad. Let me first see if I can able to share my screen. Okay. Can you see the slides?
Good morning. My name is Francesco Sala.
Oh, sorry. This is just a second. Okay. Can you see the slide?
Yes, very clear.
So thank you for the kind introduction. Thanks, Joellen, for the invitation. I'm so glad to see you guys and to see Rick after such a long time. I have to say that this pandemic is becoming really harder and harder every day because so many colleagues that we didn't see for a too long time so far. So I really look forward to meeting you in presence very soon. Now, I would like to share with you our journey through neuromonitoring spinal cord tumor surgery over the past 20 years. In Verona, we were somehow in the situation to have an historical series of about 300 spinal cord tumors operated before the advent of neuromonitoring. And since then, we have operated more or less on additional 370, 380 cases with the use of intraoperative neurophysiological monitoring. Now, this is an old slide, but it's still very much a representative of our series. You see mainly ependymomas, which are prevalent in the adult population, astrocytoma, more common in the pediatric age group, and then cavernous malformation and hemangioblastomas. Now, you're obviously all familiar with the McCormick scale, which is not a perfect one, but it's still the most used scale to assess a patient with a spinal cord tumor. It goes from grade 1 to grade 4, and usually you can consider good outcome grade 1 or 2, an intermediate outcome grade 3, where the patient still had substantial deficit, but may or may not be function independent, while grade 4 or 4 or 5 in the modified version of the scale are considered poor outcome, where the patient is usually not independent. Now, this is an old slide from Professor Bricolo before the monitoring, I think. It goes back to the end of the 90s. But I like to show this slide because it's very representative of what you should expect, even with the use of monitoring immediately after surgery. You see that just 10% of the patient come out from the operating room in the same condition that they entered the operating room. All other patients had either a mild or severe neurological worsening. And I have to say, monitoring only partially impact on this early outcome. What is most important is that monitoring should prevent from the long-term deficit. Now, as we know, most of these patients, and with time and rehabilitation, recover hopefully to their preoperative grade. So I will just go very quickly to the approach and technique, because Rick already gave a beautiful talk on this. We also use the plastic laminotomy. The approach is, in the vast majority of the cases, along the dorsal raphe. We look at the dorsal tumor surface identification. Usually at this stage, an intraoperative biopsy is done for a frozen section, though I have to say this is not very useful part of those cases where he suggests a malignancy. I totally agree that this is a forehand surgery, and it's very important to have a partner who is also skillful and with experience in this kind of surgery, because it does make all the difference. Then you look for the tumor poles and try to identify the upper and lower cysts, which are more common in ependymomas. I try to limit the use of the CUSA only for central debulking for very large tumors. Otherwise, I don't like to use the CUSA on the interface between the tumor and the spinal cord. Then, of course, the key factor in the surgery is to develop a plane between the tumor and the spinal cord. We use subcutaneous warm irrigation and try to avoid coagulation as much as possible. For the ependymoma, the goal is the total removal. For the astrocytoma, of course, depends on the plane. For the pilocytic, which are more common in children, the low grade, you can still have a pretty good plane to follow. For the more diffuse and high-grade gliomas, of course, the plane is not always visible, and that will force you in the end to a subtotal removal. And then, of course, we use neurophysiological monitoring. This is an historical picture from more than 20 years ago, when Professor Bricolo visited Rick and Fred and Vedran in New York, because he was very much fascinated by their approach, their functional approach to both brainstem and spinal cord tumor surgery with the use of monitoring. And that was the reason why then I had the opportunity to go back to New York, learn this technique, and then introduce this neuromonitoring here in Verona. Now, in terms of monitoring, of course, we monitor both SCPs and MEPs. With regards to the SCPs, you have to keep in mind that you can assess with somatosensory evoked potentials only the dorsal column pathways. So you don't have information on the spinothalamic tract and not information at all on the motor pathways. Now, one of the problems with the SCPs is that not infrequently, they may disappear or deteriorate at the very early stage of the surgery when you try to displace laterally the dorsal column. These will not necessarily reflect a permanent deficit. The SCPs are quite sensitive to anesthesia as well. So we don't use SCP changes as an absolute criteria to abandon the surgery, because otherwise we will end up abandoning the surgery too early in too many cases. So we try to maintain the SCPs as long as possible, but unless there is a specific reason to abandon the surgery at that stage, as long as the MEPs are present, we continue with the surgery. Obviously, you may end up in the situation where you have a patient for whom proprioception is as much relevant as motor strength, and therefore you may tailor your decision also on the goal of the surgery, the tumor histology, and the expectation of the patient. Now, there are at least 3 different techniques. I will not go into the details, but just to mention that there is at least 3 techniques in the literature that you can use to map the dorsal column. most of the time you can recognize the midline looking at the vessels which enter in a right angle through the midline. Sometimes this is not as clear as the anatomy may reflect, and therefore you may use neurophysiology to identify the central midline. You can do that by stimulating the peripheral nerve and record from a miniature electrode on the spinal cord. You can stimulate the dorsal column and record for the peripheral nerve, or you can stimulate the dorsal column and record from scalp electrodes and look where you obtain a so-called phase reversal of the SCPs, which will occur when you cross the midline. Now, of course, the motor potentials played a major role in spinal cord tumor surgery, and you can basically stimulate the motor cortex transcranially and record both from the spinal cord and from the muscles. Now, if you record directly from the spinal cord, you use a single stimulus and record from an epidural electrode, which is placed caudally to the level of the lesion. And this will give you the so-called D-wave, which is a direct activation of the fast-conducting fibers of the cortical spinal tract. So by doing that, you elicit synchronous volley, which travel along the cortical spinal tract and can be picked up and recorded by your epidural electrode. Why is this D-wave so important? Because the D-wave reflects the activity of a small amount of the fibers of the cortical spinal tract, probably no more than 2% of those fibers. But these are the largest fibers, the better myelinated ones with the fastest conduction velocity. And therefore, these are the critical fibers to support locomotion. So we have learned over these many years that as long as the D-wave is preserved, we should expect a good long-term motor outcome, while when the D-wave is lost or worse for more than 20% of the initial amplitude, this is usually a poor motor outcome. Now, interestingly, unfortunately, the D-wave is less monitorable in patients who arrive to surgery in poor McCormick grade. So the monitorability of the D-wave at baseline at the beginning of the surgery ranges from 80% in McCormick grade 1 patient down to 30% in McCormick grade 4. So paradoxically, the patient who would need it monitoring the most are those who are less monitorable. What we have also observed is that the monitorability of the D-wave is lower in patients with extended serines or cysts. And also the monitorability of the D-wave decreases in patients with very extended tumors. So if the tumor extended for more levels, that decreases the monitorability of the D-wave. So there is an interesting phenomenon which we have observed with Rick and Fred and veteran elite Carl Bauer 20 years ago in New York. And these are patients who arrive to surgery in very good condition. They have good muscle MEPs. They are in McCormick grade 1 or 2. But in those patients, we were not able to monitor a D-wave. And this was more frequent in patients, again, with extended serines, with multi-level spinal cord tumors, in young children, and patients who received spinal cord radiotherapy. Now, what these patients have in common is probably the fact that the cytoarchitecture of their spinal cord is modified, either because of the size of the tumors, the presence of the cyst, the maturity of the cortical spinal tract in children, or the effect of the radiation. So what happens is that the different fibers, most likely they can still conduct, but they are not synchronous, they are desynchronized. And therefore, each fiber travels at a different, conducting with a different velocity, so that you don't have the possibility to record a D-wave at the spinal cord level, although then you have this temporal and spatial summation of firing at the level of the alpha motor neuron, which allowed to have a muscle response. We don't have a proof of that, but this is a theory, but in some patients, in spite of their good motor condition, we might not be able to monitor the D-wave at the beginning of the surgery. Recently, the question was risen in the literature whether or not the D-wave truly represents a strong predictor of long-term motor outcome. And in fact, if we look at the literature, we consider D-wave as a gold standard for more than 20 years. But actually, most of the papers were all coming from the New York school. And in a recent paper in JNS, it was pointed out that although the D-wave monitoring was considered the gold standard, there was no study in the literature which specifically addressed the issue of the D-wave accuracy in spinal cord tumor. So we decided to go back to our Verona series and look specifically at the D-wave monitoring results. So we review about 300 spinal cord tumors where monitoring was consistently used. These were more ependymomas, followed by astrocytomas and cavernomas. And to start with, there were 14.7% of the patients where we were not able to, where we didn't even attempt D-wave monitor. And this was in 24 cases because the tumor was too caudal, so there was no possibility to place a D-wave caudal to the conus caudal level. And in other cases for other logistical technical issues. And then D-wave monitor was attempted, but the D-wave was not monitorable in additionally 75 cases, either because the patient had a severe paralysis before surgery, or for technical problems, or most likely for the desynchronization phenomenon. So as a matter of fact, in the end, D-wave was monitorable at the baseline in 60% of these patients. Now, when we look at the correlation between the D-wave and the outcome, the monitorability, you see that the monitorability rate was much better for ependymomas than for astrocytomas, although this most likely reflect the fact that patients with ependymoma tend to arrive to surgery in better McCormick rate than those with astrocytoma. The other point, and in fact, as you can see here, the McCormick grade 3 and 4 was 30% for the astrocytomas and 10% for the ependymomas. And then we confirm again that there is an inversion, an inverted relationship between the McCormick grade and the monitorability rate, much higher for grade 1, lower for grade 4. Then when we look at the clinical outcome at this chart, you can see that in spite of the preservation of the D-wave, still we had a large majority of patients who get worse to McCormick grade 3 and 4 immediately after surgery. So remember, D-wave monitoring does not predict the early outcome. These were most likely the patients who preserved the D-wave but lost the muscle MEPs. But when we look at the follow-up results, there were only 9 patients out of 160 in McCormick grade 3 and 4, and out of 3 with McCormick grade 4, 2 of them were already in McCormick grade 4 before surgery. Now, this is probably the most important slide of my talk. And this slide tells us that whenever that we were able to preserve the D-wave at the end of the surgery above the 50% baseline amplitude in 91% of the cases. And as a result of that, 94% of those patients were either McCormick grade 1 or 2, so they were able to walk independently at the follow-up. So that means that if you monitor the D-wave and you succeed to maintain the D-wave throughout the surgery, you have a 94% chance that the patient will be able to walk independently at the follow-up. Now, the other point is that we had to abandon the surgery in the entire series in only 3 cases because of monitoring, of irreversible changes in monitoring. This is one of those cases, was a patient with a T2, T3 astrocytoma, preoperative McCormick grade 1, D-wave drop more than 50%, left side muscle MEP disappear. We decided to stop, not to take the risk of a permanent paralysis and hoping for a recovery. The patient get worsened. He had no muscle MEP on the left side at the end of the surgery. He get worse to McCormick grade 3 post-operatively. We left a small remnant of the tumor, but then he made a full recovery. But this is only one of the 3 cases where we were forced to abandon the surgery because of monitoring. So our conclusion was that monitoring is safe D-wave monitoring is a safe technique, and in an asymptomatic patient is monitorable in up to 80% of the cases. It is highly influenced by the preoperative McCormick grade. The false positive results were between 1.1 to 2.8%, depending on how you interpret the transient intraoperative changes, and the false negatives result were 1 to 1.1%. So we recommend the routine use of D-wave monitoring and to maintain the 50% threshold as a threshold warning criteria to stop the surgery. Now, D-wave monitoring is combined with muscle MEP monitoring. To do so, you have to use a train of stimuli to bypass the anesthetic effect, which would block otherwise the transmission across the synapses. So using a train of stimuli under general anesthesia, you can still have a muscle response because the train allows to bypass the blocking effect of the anesthetic at the level of the alpha motor neuron. And therefore, you can still record muscle MEPs in the asleep patient. Now, these were the criteria established by Vedran Delitis 25 years ago. Basically, if the D-wave is present, the muscle MEP are okay, you would expect a good motor outcome from early after surgery. If the muscle MEPs are lost, you should expect a transient motor deficit. The point of no return is when the muscle MEPs are lost and the D-wave is also lost, because that is predictive of a long-term motor deficit. So from a practical standpoint, what we do, if the D-wave muscle MEPs are stable, the surgery can continue. If we have minor changes with the MEPs, we try to move the surgical manipulation to a different area. Maybe you go to the other pole of the tumor, you're trying to move to the right or left side or vice versa. But as a rule, surgery can continue. If the muscle MEPs are lost uni or bilaterally, we stop the surgery and we wait. Time is a key factor to facilitate the recovery. We try to irrigate with warm saline to maintain the temperature. In some cases, we use local irrigation with papaverine, and we try to correct any hypotension and possibly to induce a slight hypertension to facilitate spinal cord blood flow. In this case, you should expect transient motor deficit, of course, affecting the involved extremity. If the muscle MEPs are gone and the D-wave drop more than 50%, we stop surgery immediately. And if the D-wave does not recover with the corrective measures, we abandon the surgery to diminish the risk of possibly having a permanent motor deficit. Now, sometimes you don't have a D-wave monitorable. So if you ever to rely only on the muscle MEPs, I would recommend to be more cautious because you cannot differentiate between a transient and a permanent motor deficit. And therefore, in selected cases, it may be wise to decide to abandon the surgery when the muscle MEPs start to be very unstable. So this is the tip that we use. The acronym T stands for time, wait. Sometimes I don't mind to wait 20, 25 minutes, half an hour if needed, to allow the spinal cord to recover. And when the potential are back, we can resume the surgery, irrigation, and control blood pressure and perfusion. Rick mentioned about the bulbocavernous reflex. It can be very helpful, especially if you have a conus cauda tumor. The BCR allows to assess the functional integrity of the S2 to S4 segments of the spinal cord and to monitor the pudendal nerves. Just a couple of comments about monitoring in children. In babies, you may have the motor cortex displaced more frontally. So you have to advance the position of your electrodes to hit the motor cortex more effectively. And sometimes it may be difficult to get MEPs in young children due to the immaturity of their motor cortex and motor pathways. But as a general rule, they are quite monitorable even in the in the babies. With regards to the monitorability, it is well known that there is this correlation between the MEP thresholds in younger children and the age. So the younger is the child, the higher might be the intensity you need to use to elicit a response. But as a general rule, muscle MEPs are monitorable also in very young children. This is just an illustrative case. This was a 10-year-old boy with a short history of neck pain who came to us several years ago. He had this bad-looking tumor, which was involving also the medulla. So we monitor SCPs, MEPs, D-wave, lower cranial nerves. At surgery, we had pretty much stable MEPs on the left side, while we progressively lost all the MEPs on the right side, except for the abductor hallucis. But the D-wave was very stable throughout the surgery. And since there was a surgical plan that could be followed based on the persistence of the D-wave and the fact that the muscle MEPs were lost only one side, this was predictive of a transient motor deficit. We decided to continue with the surgery. At the end, the child woke up with a severe tetraparesis, which was more marked on the left side. He had also some swallowing problems, but this is him 3 months after surgery. You can see that he still had eclampsia with his right hand, which then completely recovered within about a year. And he also completely recovered from his lower cranial nerve deficit. This was the post-operative MRI. This was a pilocytic astrocytoma, which is completely removed. So this child is now cured. So basically, we can use neuromonitoring to have controlled risk when you try to be more aggressive, of course, if there is a neuro-oncological justification for it. So in general, I like to call the ependymoma and the astrocytoma, the ependymoma behave like the good one of the Sergio Leone movies. They have a good cleavage plane. Here, the goal should be to achieve a total removal and to preserve function. Astrocytomas can behave like either the bad or the ugly, depending on the histological grade. Pilocytic astrocytoma in children can still be amenable or total resection in a good amount of cases. But as Shlomi Costantini and Fred and Rick showed, if you're able to remove around 70 to 80% of the tumor, you can still grant these children a very good outcome and a good control of the disease. So of course, here you have to privilege the preservation of function. Just a couple of quick note about direct mapping of the spinal cord to monitor, to map the motor pathway. There have been a few papers in the last decade that suggest that you can stimulate directly the spinal cord to identify the cortical spinal tract. This is a very nice paper from Cohen Gadol, where they show basically almost a somatotopy of the different muscles by stimulating the spinal cord and recording from the muscles. Now the problem, this is a video that I took at the end of the removal of an ependymoma. Now you will see here, I'm stimulating within the surgical bed from inside out towards the cortical spinal tract. And here we had a nice response from the abductor, I think it was the right APB.
Minima risposta alla mano.
Now we are stimulating on the dorsal column, and you wouldn't expect any response. But as you will see in a second, even stimulating from the dorsal column, we still had a motor response from the right
Qua abbiamo
tibialis
sempre tibiale e piede.
and the abductor hallucis. So the problem is that you may still have a motor response when you stimulate the dorsal column through an antidromic activation of the dorsal column pathway, which then have a synapses with its interneurons, which go into alpha motor neuron, and then you have a motor response similar to what happened with an H reflex. So the bottom line is that if you stimulate the spinal cord and you get a motor response, you cannot be 100% sure whether or not you are stimulating the motor pathways antidromically or the somatosensory pathways orthodromically. Now with Vedran Delitis and Kathleen Seidel and Carl Kottbauer, we were able in the end to find a solution to that problem, which consists in the use of a double train. So you basically stimulate the spinal cord twice with 2 consecutive trains. Now, due to the refractory period of the interneurons, if you are activating the true cortical spinal tract with 2 trains, you will have 2 responses. While if you are stimulating dorsal column, you will have the first train, but not the second one, because the second train will be blocked by the refractory period of the spinal cord interneurons. This is just a preliminary study, but it's an interesting technique to try to discriminate between sensory and motor pathways. And I will move towards the end, just say a couple of things about evidence-based medicine neuromonitoring. Rick was very kind, saying that with the 2006 control study, we closed the discussion about the value of monitoring spinal cord tumor surgery. I have to say that unfortunately that was not exactly true, because I kept seeing and discussing a publication even very recently on the value of neuromonitoring in spinal surgery and spinal cord tumor surgery. This was an editorial by Andrew Jaya that just a few years ago was wondering if neuromonitoring is a gold standard or fool's gold. I have to say that I've abandoning the hope to solve this never-ending story. I became kind of exhausted by the discussion. Some of you may be familiar with the so-called North American guidelines on the use of monitoring in spine and spinal cord tumor surgery, which were, to some concern to me, endorsed also by the WNS and the CNS. This publication, which almost demolished 2 decades of work in the field of neuromonitoring, concluded that there is class 1 evidence that monitoring is a valid diagnostic test, but there is no meaningful medical evidence, therefore randomized clinical trials or class 2 evidence study to support the fact that monitoring can prevent rather than merely predict the outcome. And they went as far as saying that therefore, due to the lack of class 1 evidence, the costs of monitoring are not justified. So for any neurosurgeon around the globe reading this paper, the take-home messages are that monitoring can only predict but not prevent spinal cord injury, and therefore is not cost-effective. Now, the idea behind is that everything that is not supported by class 1 or 2 evidence cannot be recommended as standard of care because it does not represent meaningful medical evidence. Now, if we look at our own practice as neurosurgeons, you may be surprised to know that only 10% of what we do every single day in the operating room is based on class 1 and class 2 evidence. But interestingly, no one questioned the value of neurosurgical procedures to the same level that they question the value of neuromonitoring. Although if you look at the facts, the evidence we have for the value of neuromonitoring is no less than the evidence that we have for the value of what we do every single day in our operating room. So of course, this is a long story and there is no time. This would deserve another talk. But obviously the reason for that American paper were the high level of medical legal litigation in North America in spine surgery. If I have to summarize my thought on this, I think that to protect spine surgeons from the risk of monitoring related lawsuits, especially in North America, where neuromonitoring is a big business, but often of poor quality, the indications for monitoring are sometimes unjustified, the evidence of monitoring is still controversial, and the incidence of medical legal litigation is outstanding. This is to some extent legitimate and also necessary. At the same time, to radicalize the concept of evidence-based medicine and claim that monitoring is only a diagnostic test is useless to prevent neurological deficits, and the cost of monitoring are unjustified, would expose the risk of denying surgeons and ultimately our patient of a potentially useful technique from which they could benefit. So I think that the balance between protecting ourselves and protecting our patients is truly walking on a very fine line. But if I have to look at facts, this was an interesting paper published a few years ago from our colleagues in Dublin, which was entitled Gross Total Resection of Ependymomas using the strategy of en bloc resection without neuromonitoring. And they presented 17 patients where they had a gross total resection rate of 94%. They said there was no statistical difference between the pre and post-operative McCormick score between their series and other published series with the use of monitoring, but that the gross total resection rate compares favorably with that published series where monitoring was used, claiming that basically neuromonitoring would prevent a good oncological result because it would result in incomplete resection in too many patients. They were quite, I would say, also brave in proposing their series as a benchmark for the value of neuromonitoring in spinal cord tumor surgery. So solicited by this study, we review our experience in Verona with ependymomas. And this series has just been accepted for publication in JNS Spine. So we review 100 spinal cord tumors, all operated consistently with the use of neuromonitoring, including D-wave monitoring. Our gross total resection rate was 89%. Of course, you have to consider the weight of a gross total resection out of 100 as compared to out of 17 patients. But when we look at the McCormick grade in the two studies, you can see here that the McCormick grade 4 was 0% in the series without neuromonitoring and 3% in our series pre-operatively. Post-operatively, the McCormick grade 4 increased to almost 12% without monitoring and just 1% from 3% to 4% with the use of neuromonitoring. So I think there is evidence that monitoring does not prevent a good oncological results. And of course, we have to improve the evidence for the value of monitoring, but I certainly would never accept to enter a randomized clinical study where I would assign patients with spinal cord tumors to a control group where neuromonitoring is not used. I would rather stop here and very glad to take any question. Thank you.
Thank you, Francesco, for this nice presentation. Actually, very interesting. And do we have any questions?
Francesco, this is Rick. I would add the rather biased opinion that I still will say that you won the argument with your paper, and you can't really, you're not going to convince the people that are unintelligent and can't look at evidence and weigh it. So I think thoughtful neurosurgeons know that monitoring works.
So sometimes
papers are now getting accepted in the journals, where in the past they wouldn't even let them into the journal.
Sometime very recently, comment that in your monitor you either have believers or non-believers, and there is no way you can change their mind. And I'm pretty much convinced that's the case in some cases.
Yeah, they probably don't believe in vaccines either.
Well,
The question.
can I make a comment?
Okay. Yeah.
Now, of this, may I make a comment?
Yes, please, Kiki, go ahead.
Yeah. So, well, of about, I've done about 300 plus intramedullary tumors, and my initial 150 or so tumors were done without any monitoring. In the government hospital, we didn't have any monitoring device. And later on, we started getting things, and we have done with neuromonitoring, but without D waves. My results have been almost the same without monitoring and with monitoring. And when I look back at my series, I don't see any, well, I don't know whether it's something to do with surgical technique, but the results have been almost comparable with or without monitoring. The morbidity of the patients post-operatively, both immediate as well as long-term, have not been significantly different. That's one point. And even when I was doing monitoring, if there were times when I found that the MEPs were going down, but if I knew that my plane of cleavage and my ability to handle the spinal cord was quite adequate, I did not stop, and I continued to operate and remove the tumor. And I did not find any great neurological impairment. I'm talking about long term. Well, short term, for a few days or a few weeks, they may get affected, but long term, there was no significant difference. So I'm not trying to say that neuromonitoring is good or not good, and that it should be, but the question that arises to my mind is medico-legal. If on a given day, today we all have monitoring, but if on a given day you find that your equipment is not available, or the technologist or the physiologist is not available, and you have a case that you have to do, should you postpone it? Or if you don't have the equipment at all, it's gone kaput, would you consider operating? Would you transfer the patient to some other facility? Or if you are experienced enough, would you continue to operate even if you do not have monitoring? So these are, I'm sure you don't have these questions arising in well-equipped or you can say well-endowed universities. But this is what I would face in India. And what would I tell my youngsters who are operating in, let us say, in small towns where nothing of this kind is available? Would you encourage them to continue operating if they are reasonably well trained, or would you then ask them to transfer the patients to some? A very difficult question for Verona or New York to answer.
Yeah, no, thank you. This is a very important question, actually. It's a question that we have been debated for years. Now, regarding your experience, well, there are different things that one can say. One is that probably you were very good to operating on these tumors even before you had the monitoring. So of course, the experience of the surgeon makes also a difference on the impact of monitoring. Although I have to say that it was quite enlightening for me to observe that both Fred Epstein and also my mentor, Professor Bricolo, by the time they introduced monitoring, they had a huge experience on spinal cord tumors. And in spite of that, they saw the importance of that, and they accepted in the late stage of their career to have this neurophysiological guided approach to monitoring. Now, certainly the use of the D-Wave, I think, is essential. So it might be that only with muscle MEPs, it's more difficult probably to find a difference because you cannot really differentiate between early with the short-term or long-term deficit. But obviously, if you tell me that when you are comfortable to proceed in spite of the drop of the MEP, you proceed, then it's also difficult to compare the use of monitoring versus the not use of monitoring, because if you don't change the surgical strategy based on monitoring, then you cannot have a control group. Now, this being said, I'm totally aware of the medical legal implication, and I think that in general, we have to be very cautious when we define something as standard of care. So from that point of view, I understand the North American paper. What I don't agree with is to put everything on the same basket, because in that paper, they put apples, oranges. So one thing is to discuss the value of monitoring in a cauda equina neurinoma or ependymoma. different story is on pedicle screw placement, different story is on a spinal cord tumor. So to answer to your question, in Verona, if for whatever reason I don't have monitoring available, I would cancel the case nowadays. Whether or not somebody without monitoring should send the case to a center where there is monitoring, I think if you have a center nearby that can do the surgery with monitoring, as much as I know how difficult it is for us as a neurosurgeon to give up a case and send the case to somebody else, I think that should be the right thing to do. So, if I have a complex cranial synostosis that I don't have experience to treat, or don't have the best maxillofacial plastic surgeon, cranial and neurosurgeon team, I send to my colleagues who does this every day with all the equipment and the team. So I think the same thing should apply for spinal cord tumors. I think that specifically for spinal cord tumors, I'm not talking about other spine surgery, but for intramedullary spinal cord tumors, these cases in 2021 should be done with neuromonitoring. Then, of course, there are countries with limited support, both in terms of technology and expertise, because you may have the monitoring equipment, but if you don't have a trained neuromonitoring professional, that's equally a problem. So now, then you do whatever you can do. And of course, I understand it can be practically difficult to send all patients abroad or to a different center. But in Europe, in Italy, in North America, I think it would be wrong to operate a spinal cord tumor patient without neuromonitoring nowadays.
Yes,
I totally agree with you.
I may.
We also in Egypt, we postpone any case if the monitor is not available, especially in intramedullary, in kids especially. So Moody Qureshi, please, you have a question?
Just adding to the debate, I think we can't at this point in time say the jury is out and we haven't got an answer. I think the current evidence suggests that we do have an answer. And taking on Keki's point about low and middle income countries not having the facilities, what do you do from a medical legal perspective? I think you do what you always do with any tumor. And you say, look, this can be done better with someone else, but you have to be willing to travel there. And sometimes it means traveling abroad. And but if the question to, and that's what I tell to the patient, is the question to you is, to me is, can this be done reasonably safely, and you're prepared to take that additional small risk, then please let me know, go and decide, come back. And you will find they will go and take other opinions because you've given them a very sound and honest opinion. They come back and say, look, we cannot afford to, we don't have the insurance cover to take us abroad. Are you able to take us through this by minimizing the risk? I think then if you've documented that and you do what you need to do, I think it's safe to do so. I mean, we've started using a fairly, I won't say low level, but a modest level of neuromonitoring in some of our hospitals in East Africa. And we've seen the benefit. But again, Keki's experience of taking them out without neuromonitoring, the question to my mind is, how many of those did you have an MRI on? Because sometimes even the MRI was not available. So you don't know whether you had a subtotal resection and you thought you did well. And that happens to us all the time. You come out taking a glioma out and you feel you've taken out 90%. And then when you take the MRI, you realize you've only taken out 50% or 60%. So was that the issue with some of those cases, Keki? Not sure. So I think unless we've actually gone through a very detailed evaluation with MRIs, it will be difficult to judge that there was really no difference between the cases using neuromonitoring and those whether you didn't use monitoring. I'm not saying that the technique was different, but we haven't got evidence that there was documented MRI imaging to show that the results were actually very compatible. So there's a lot of debate, but I think the pendulum, to my mind, has swung to the point where if you have the neuromonitoring and you opt not to use it because you were in a bit of a rush to do it because the neuromonitoring expert was busy at another hospital and you weren't prepared to wait for another day or a few more hours, and then you went up into a difficult situation, I don't think one would have now the ground to stand on and say, look, I did the best, because one hasn't. So I'm trying to take on board all the various things that have been discussed, including Keki's excellent argument. And working in a low and middle income country, I still have to face those situations, but I think there has to be some way of balancing it out. Thank you for allowing me to share my thoughts.
I totally agree. You have to contextualize, of course. So there is no that, paradoxically, I think countries where there are limited resources to warrant neuromonitoring niche and single case might be in the best position to truly perform a randomized study. Because if you don't have the chance to monitor all the cases, because you can afford to do 50 monitoring a year, 40 monitoring a year, because that's what the context offers in terms of expertise and financial support, then it would probably be ethical to say, we can do more than that. And we still are forced to do, and for some of these patients without monitoring for whatever reason. So then I think it could be considered the value of randomizing, but that would not be acceptable to me in Europe and North America.
The same would apply. I wouldn't be able to randomize in the same hospital, because just like where Keki works, we work sometimes in the public sector where the resources may not be there. And then we have excellent private hospitals where the resources are there. I could justify a randomized trial and say, look, this is not available, cannot be accessed or sourced because of cost issues by the public hospital where I'm working, but I am able to do so at this particular institution. There, I wouldn't be able to justify randomizing patients. But doing the same kind of surgery in two different settings, I think you're right. One could justify that, provided you get it through the ethics committee of both hospitals, of course.
If I could just add to that, Francesco, let me know your thoughts. I know some of this I've kind of learned from discussions with you or listening to you talk on this. But I mean, it's important to remember, especially for young neurosurgeons or young neurophysiologists, that monitoring is a tool. Like imaging, intraoperative imaging is a tool. Like endoscopy is a tool, and really, it's only as good as it's interpreted. If we're comparing monitoring to non-monitoring, perhaps we should clarify the point that you have good monitoring and bad monitoring as well. And if you compare, some of those sort of bad monitoring things, then it can easily, whether for whatever reason, interpreted wrongly or done wrongly, or in the context of medical legal context where it's done just as a routine to show that we didn't make the effort to monitor, which in a lot of private practice cases, is exactly the case. I think for me, in the context of developing a sort of, and I mentioned this to Francesco previously, developing a curriculum where one trains people adequately and you have some sort of quality check, where people are adequately trained to do intraoperative neurophysiological monitoring. Because at the moment, Francesco, and maybe just make a comment, I'm not sure what the actual check is. If you're a guy running a private practice, you book a physiologist, they come in, do the monitoring. You have no sort of way of knowing, how experienced they are, how advanced they are, particularly if you're doing kids, for instance. There's quite a reference range between somebody doing the monitoring for children versus adults. Do you just get somebody coming in who's never really done monitoring in a child before, who does that for you? How reliable is that? And how much of your decision making do you base on that? And I think any monitoring tool or any quality control tool should well, in some cases, give you the ability to resect more, but in other cases, also limit your resection. So your outcome measure needs to be clear, not just gross total resection, but like you pointed out, also, clinical outcome scores. So we've got to do all these checks and ticks. And I think it's not a simple kind of binary comparison of, is monitoring good or bad or better without it. So those are, yeah, look, I don't think it adds to the to the outcome of the debate, but certainly, adds to the complexity, I think.
Yeah, no, I agree with you, Leo. And I mean, the quality of monitoring has, it's essential. One of the problems with some of the published papers, which were questioning the quality of the monitoring, very often was the quality of the monitoring the paper, not the quality of monitoring, the value of monitoring per se. So again, we have to be very careful in what we publish and what we read. And there is no doubt that you cannot improvise becoming a neuromonitoring professional. I remember, and Rick remembered that very well, Vedant Delitis was not taking anyone for less than 18 months to 2 years. Because he said, less than 600-700 cases, you cannot be able to monitor independently. And of course, this is very difficult to achieve. And monitoring, especially in some countries, is a big business. So there are companies sending you the tools, and they train neurophysiologists, who's maybe a technologist who has spent 3 months doing 30 cases and then goes and monitor your case. And then you are in trouble. So when that scenario comes up, probably no monitoring is better than bad monitoring. And it's very complex. I mean, no doubt, no doubt.
There is a question from a neurophysiologist. She's asking whether corkscrew electrode placement for children should be modified in order to accurately obtain MEPs in comparison with adult monitoring, and what other important differences are there between monitoring children versus adults in terms of electrode placement and types of electrode and techniques.
Oh, that would be a long answer. Now, about pedicle screw, I don't know if I got the question right, but pedicle screw, I mean, you can use monitoring to see whether or not you have a breach in the canal and have the screw which is going close to the nerve roots. And there are thresholds.
Not the corkscrew that you insert in the...
Sorry. Okay, yeah. So corkscrew, you can use corkscrew in children. Yeah, just to be careful in babies with an open fontanelle. And in children, we may have a shunt just to avoid puncturing the fontanelle or the shunt with the corkscrew. So in neonates, you can use cup electrodes or surface electrodes. But other than that, corkscrew have a very good impedance, and we use routinely also in young children. And then in general, as I said before, the younger is the child, the more immature is his her motor system. So you have to sometimes use higher intensity or longer train, or you can use some double train technique or peripheral facilitation to improve the MEP reliability and monitorability. So there are some technical adjustments you can use in children versus adults. But in general, I would say that you can perform neuromonitoring mapping. Sometimes we map mere meningocele on 1 day of life to map the roots, and that comes out beautifully. So monitoring is in general feasible, depends also on the technique, but also in very young children.
Yeah. Any more questions, Leo? You see any more questions?
I don't see any. Just Francesco, something that we've picked up now, actually doing the ticks and checks and trying to set up a kind of robust system, is that the D-Wave electrode appears to be a lot more expensive than I thought when you actually have to purchase it as an individual item. Is that something you've picked up, or is it just an anomaly that we have down here?
It's a good question, because I don't know the cost of the electrode now. It's organized by the hospital and your monitoring team. I can ask them, but I would expect, you're saying that they are more pricey now than they were a few years ago, or?
I don't know what they were a few years ago, because I never had to actually look at the budget for them. But now having to purchase, them as individual items.
send me an email. I can find out for you what we pay for our lecture and see if
Oh,
they are cheaper.
But you can reuse it. I think they get it as a disposable, but we use it. We just sterilize it by plasma and we reuse it. Do you do the same, Francesco? Or
Yeah, you can
just
sterilize them. I mean, some of them are they can be re-sterilized. Of course, many times the company ask for disposable, but when I came back from New York 20 years ago, I have my package of electrodes for mapping the brainstem or whatever, and we were using them all the time after re-sterilization, never had a problem. So again, it's a matter of resources, but some of these are cleavageable.
Yeah, we did the same in New York when Vedran was developing the protocols back in the late 80s. We'd reuse them.
On that note, Francesco, so something I've become really, or I've enjoyed using is the stim, the suction stim. I think Robbie makes that. Is that something you have experience with? I think the more I've used it, the more I've enjoyed using it.
So I use it quite often for brain gliomas. I don't use it for spinal cord tumors. Honestly, in spinal cord tumors, I found mapping techniques interesting, but not very useful. So it's quite unusual that you go and map the cortical spinal tract to tailor your resection. It's so tiny, and again, I don't use the CUSA on the cleavage plane between the tumor and the spinal cord. So I always do this peel away technique to try to separate the spinal cord from the tumor. So it's interesting sometimes to map and see if you are close to the cortical spinal tract. But right now, I would say that mapping techniques in the spinal cord are more interesting from a research standpoint than from a practical standpoint. I would say that MEPs and D-Wave and ACPs are still relevant. So, but I use it routinely for the brain gliomas, for subcortical mapping, because you have the advantage that you can stimulate and use the suction at the same time. So you don't need to stop, stimulate, take more tumor, then stop and stimulate again. So that improves the reliability of subcortical mapping. It's a nice technique.
Yeah.
I just have one general question amongst people who have been out doing pediatric and adult. Is it, how do you compare manipulation of the spinal cord tumors in children compared to the adults? Do they withstand this manipulation better or the same or worse than the adults? I don't know if anybody has the answer.
My informal observation is in children, the sensory system seems to handle the manipulation a lot better than it does in adults. Watching Fred's patients, we would, on the adult patients, we would tell all of them preoperatively that they would have proprioceptive deficit. And we did not have to have that discussion with the children. It could happen, but it was much less likely.
About proprioception, it just comes to my mind that, the more we were able to preserve motor function, the more the patients now are coming back complaining for sensory deficit. So we should probably give some dignity back to the ACPs, because we have some patients with perfect MEPs and they are unable to walk.
Yes.
So
Yes.
this can be very, very impairing for their quality of life. So we were so enthusiastic about MEPs that probably we paid too less respect to the ACPs over the past 20 years. And we might need to try to preserve them as much as possible again.
Yes.
I thoroughly agree. I will say that, since going to the amount of trouble that I did open it up in the median raphe, that the sensory deficits that I'm seeing are much less dense than they were before, but they're still there. And the older the patient, the higher the risk for them occurring.
Just one last question. I see John's forwarded this on to me from Pragnesh Bhatt, asking what is the consensus regarding intradural extramedullary tumors? I suppose monitoring in that context is the question, Francesco.
No consensus. No, again, there have been now a few nice papers about looking monitoring extramedullary tumor. Well, for those, I think if you have monitoring, I think it's wise to use it. You can still have some benefit. I wouldn't stress the need to use monitoring for the extramedullary as much as for the intramedullary. But as it was pointed out before, if you have monitoring and you don't use it, you are more liable medico-legally than if you don't have monitoring at all. So, if in Verona I take out a caldequina tumor or a thoracic meningioma without monitoring, and then I have a problem, it would be very difficult to say, well, was an extramedullary tumor, I didn't dare to use monitoring. So now we move into that area where, of course, the indication for monitoring should correlate with the risk of neurological deficit. So the higher risk, there is no doubt, is for the intramedullary. Then, of course, you have the extramedullary, then you have the spine surgery, you have the fusion, etc. So if you have monitoring, you have the possibility to have monitoring for most of your cases, just use it. If you don't, I would say, you can still do an extramedullary tumor without monitoring. I wouldn't do an intramedullary one. That's my perspective.
That's an interesting point, probably a discussion on its own, yeah. Okay, Mo, I'm gonna hand over you to just wrap up and make some closing comments, man.
Yeah, thanks for Francesco, thanks Rick for the nice presentation. And of course, thanks for all the panelists. It was very fruitful discussion. Thanks, Modi, for the support. And I just say that next month we will not be having the regular monthly webinar of the pediatric section. So we are working on to have a IPM course instead in October. So perhaps we will set it up and thanks, John, for the broadcasting. Was excellent. And yeah, thanks, guys, and we hope to see you in person next year, hopefully.
Thank you.